This video provides an overview of autologous hematopoietic stem cell transplantation, or HSCT, and its management in the bone marrow transplant unit and step-down ward. There are three main types of HSCT: autologous SCT, allogeneic SCT, and haploidentical SCT. The autologous transplant process involves collection of stem cells, processing, cryopreservation, chemotherapy, and reinfusion. It is often used for multiple myeloma and lymphoma. The goal of autologous stem cell transplantation is to deliver high-dose chemotherapy, followed by the reinfusion of the patient's own cryopreserved cells. Advantages of autologous SCT include being safe with a low treatment-related mortality, faster immune recovery, and less incidence of VOD. Disadvantages include possible contamination with malignant cells, no GVL effect, and a higher risk of relapse. Autologous SCT is a procedure where a patient's healthy stem cells are collected, stored, and then given back after high-dose treatment. It is commonly used for blood cancers, like lymphoma and multiple myeloma. The transplant timeline includes chemotherapy or radiation treatment before transplant, the transplant day, and the recovery period after transplant. The stages of stem cell transplant include conditioning, harvesting, infusion, and engraftment. These procedures are used to treat certain cancers and autoimmune disorders. The timing for transfer to the step-down ward varies. For multiple myeloma, it is D+2 or D+3. For lymphoma, D+12. And for acute leukemia, engraftment usually D+15 to D+17. Complications that may arise after HSCT include febrile neutropenia, ABO incompatibility, and the need for transfusion support, mucositis, and engraftment syndrome. The first complication we will discuss is febrile neutropenia. Post-HSCT side effects, or cytopenia, increase the risk of infections, anemia, and bleeding due to low blood cell counts. Other common issues include nausea, vomiting, mucositis, and fever. Febrile neutropenia is defined as a single temperature greater than or equal to 38.3 degrees Celsius orally, or 38.0 degrees Celsius over 1 hour, while the ANC is less than 500. Management of febrile neutropenia involves a history and physical examination, attention to oral and perianal areas, and gram stains. Empiric antibiotics are given, and patients are promptly reevaluated if fever persists. Empirical antibiotics should cover Pseudomonas and address the risk of resistant bacteria. Options include third-generation cephalosporins or carbapenems. Vancomycin may be added in specific situations, and follow-up hemoculture is needed. Other orders for post-HSCT care include various medications for prophylaxis and supportive care, such as antiemetics, pain relief, sleep aids, and nutritional support. Next, we will review ABO incompatibility and transfusion support. General considerations for transfusion support include ABO-RH compatibility, leukodepletion to prevent CMV transmission, and gamma irradiation to prevent transfusion-associated graft-versus-host disease. All blood components for HSCT patients must be leukocyte-reduced and irradiated. Leukocyte reduction minimizes febrile reactions, alloimmunization, and CMV transmission. Irradiation of cellular blood products is crucial to prevent transfusion-associated GVHD, which presents with fever, rash, diarrhea, and high mortality. 25 grays of gamma radiation is used to suppress the proliferation of T lymphocytes in blood components. This irradiation shortens the shelf life of RBCs to 28 days and platelets to 2 to 3 days. The duration of irradiated blood product use differs for autologous and allogeneic HSCT. For auto-HSCT, it's until at least 3 months post-transplant, while for allo-HSCT, it's longer. Transfusion thresholds for RBC support are generally 7 to 8 grams per deciliter of hemoglobin, or 8 grams per deciliter for those with cardiovascular disease. Platelet support is given at levels of 10,000 to 20,000 per microliter to prevent spontaneous hemorrhage. The third complication is mucositis. Mucositis, or oral complications of HSCT, causes difficulties with eating, sleeping, and talking, significantly reducing the patient's quality of life. Prevention of oral damage includes patient education, encouraging self-reporting, and maintaining twice-daily oral hygiene with interdental cleaning and saltwater rinsing. Additional prevention measures include daily inspection of the oral cavity and early nutritional support, often through specialized IV drips. specific gargle solutions, such as betadine gargle with saline, and a mixture for pain relief containing xylocaine, sucralfate, and CPM syrup, are used for oral care. For pain management, a fentanyl patch of 12 micrograms per hour can be applied every 72 hours. The final complication to discuss is engraftment syndrome. Engraftment occurs when infused stem cells travel to the bone marrow and start making new blood cells. This process typically happens within 14 to 30 days post-SCT, indicated by rising blood cell counts. Successful engraftment is defined by specific blood count criteria for ANC, platelets, and hemoglobin. Poor graft function is characterized by persistent cytopenias after day 28. Engraftment syndrome is a condition that can occur during the engraftment phase, which we will now review. Treatment for engraftment syndrome involves excluding other causes, stopping G-CSF, and providing supportive care. If symptoms persist, a course of prednisolone is initiated. Thank you for watching this video on the overview and management of autologous HSCT.